Welcome, listeners, to Season 2 of Ortho Out Loud. This season is all about innovation. Today, we're talking about one of the most critical and complex parts of the human body, the spine. Joining us is a leading expert dedicated to advancing the field. Our guest, Dr. Matteini, is an orthopedic spine specialist here at Fox Valley Orthopedics. Not only is she at the forefront of surgical intervention and innovation, but she's also a passionate advocate for increasing diversity within our field. We have a lot to cover today, from breaking down frequently asked questions to the future of spine surgery and the technology making advancements possible. Welcome to Ortho Out Loud, Dr. Matteini.
Thanks so much for having me.
For sure. How does it feel to be starting out, kicking off Season 2?
I'm very excited, actually. Happy to be the first today.
That's excellent. I'm glad to have you here. Before we dive in, let's start from your beginning. How did it all start for you? What brought you to become a spine surgeon?
Ooh, loaded question, maybe. I generally will say that I had a really great mentor, and I got good at it. So I came from a really special residency program, I think, at GW University in DC, where at the time the training was very heavily focused on ensuring that all the residents had access and knowledge to all the subspecialties. So for me, I did spine every single year versus a lot of residencies now are dedicated to breaking down the subspecialties in the training practice. So I did spine from my intern year all the way through my chief year at all the different hospitals.
Yeah, I think that's a great way to do the training, so that not only are you exposed to them, but you have an understanding from your field what other people would be expecting from their patients too. Was there any key experience or moment that led you into the career of medicine?
Medicine in general?
Yes, in general.
Not particularly, but when I was a kid, I wanted to be a veterinarian. And so I guess the leading point that pushed me into medicine on humans was when one of my dogs passed away, and my dog couldn't tell us what was wrong with her, and so that was pretty sudden for us. So I decided that speaking to humans would be more fun, I guess, or more beneficial than dealing with little animals every day.
That would be sad to see your dog pass away, right?
It happens, yeah. But I love my animals and I love my patients just the same.
There you go. We know, and for any listeners who may not know, spine care is somewhat of a male-dominated specialty. As one of the few female spine surgeons in the country, how does that perspective inform your daily practice and patient interactions?
So it's been really interesting over the past couple of years to get to know more of the lady spine docs out there. And I find that a lot of the conferences we're going to are blending the neurosurgeons and the orthopedic surgeons together. There are more female neurosurgeons who work on the spine than there are female orthopedic surgeons. One of the last studies showed that there's maybe only 20 or 25 of us total across the country. So a very small number. For me, it's always been, I've been a lone wolf. I've always been the only female in any of my fellowship applications, my fellowship interviews, the first female at the fellowship. And even now, moving down, I have all male partners and all male colleagues. So having females across the country that I can tap into every once in a while at a conference has been great. But in my day-to-day, it's truly just me. I try to relish in the fact that I am a true unicorn in this area and become unapologetically who I am. And so I take all of my compassion for my patients, all of my passion for my field. I try to exude knowledge and educate my patients on being who they are and how to take care of their spine just a little bit better.
And your patients benefit from that, certainly. Of all the complex work you do, is there procedure, technique, or a specific area of practice within spine that is particularly interesting to you?
I always say that ALIF is my favorite case, which is a fusion through the belly and the lower lumbar spine. I find that it's technically one of the easiest surgeries that we can do that have the most benefit. But when it comes to most everyday spine surgery that we do, a lot of what we're doing is quality of life improvement. And so some of the most satisfying surgeries are the smallest ones, where we can do a very teeny tiny incision, remove a disc herniation or a disc fragment, and create the improvement of that patient's leg pain or arm pain with even just a simple procedure that can take 45 minutes. So try to do the best I can in small holes possible, but at the same time, they can have the largest impact.
Why is it so important to use such a small hole, so to speak, or a small incision, I should say?
The smaller incisions have less muscle stripping and less risk of infection. But if you need to use a larger incision to get your surgery done, then by all means, you want to do it safely.
Absolutely. Now let's get to some frequently asked questions. The spine is so complex and important, it's hard not to have a million questions when you show up at an office. When it comes to diagnosis and treatments, what are some frequently asked questions that you might get during your patients' appointments?
You're spot on, Scott. Everyone comes in with a laundry list of questions, and oftentimes they're all written down, which I welcome because that keeps us on task and keeps our conversation moving. One of the most frequently asked series of questions I get when it comes to spine care is what kind of pillow to sleep on, whether a hard mattress makes a difference, and what kind of sneakers I recommend. Now, everyone's got the same questions because there's a million commercials out there that'll tell you to pick this pillow and sleep on this mattress and buy my sneakers. But I find that whatever makes you comfortable. You need to get a good night's sleep, and that position's going to be different for everyone. And as far as the feet goes, you can ask my podiatry colleagues or my foot and ankle surgeons. The feet are the window to the back sole. And so having a comfortable set of shoes to get your exercise in that keeps you moving is all I can ask for.
And Dr. Bartella talked to us at length last season about different shoes and that it's not all, one shoe fits all. And I imagine it's the same thing with mattresses and pillows. Any other questions that you get frequently?
Well, there are a lot of patients who are asking about what they can do on an activity basis, how to make their back feel better, or if they're trying to exercise again and then they get hurt trying to exercise, how do they get back to doing that safely? And one of the main things that I talk about with them is going to physical therapy. And those questions will always populate with, how am I going to exercise if I have all of this pain? Well, as we try to educate, physical therapy is an extremely important treatment method to reducing pain. And so we use our physical therapist expertise to help with certain exercises, with certain stretches, tightening some of the muscles around the area that's injured in order to limit and lower the pain and then help them get back into an exercise program safely. So physical therapy isn't, again, a one-size-fits-all method of treating pain, but can be a great adjuvant in trying to get our pain thresholds down and learning all the ways and all the tools we have to exercise safely.
Yeah, I think you used a couple of really important words, or maybe the same word twice, treatment or treating, and a program, I guess, is another one where people don't just start exercising with one set of exercises and keep on that same exercise for 6 to 8 weeks, right?
Right. So having someone to help guide our exercise program, we use our physical therapist to do that, but having that guided rule in getting better with your exercises and learning how to do them safely. And then being able to move on to maybe the next machine next door or a different class that you may not have tried. So the therapy can be an extremely important program in managing symptoms and getting back into exercise.
Getting them out of their pain. They don't have to worry about the pain as much then.
That's the idea.
What would you think is a common misconception regarding spine?
So one of the main things that I talk about with pretty much every person that comes through my door is their arthritis. And one of the most common misconceptions is that arthritis doesn't hit everyone, when in fact, every human on the planet will at some point have arthritis in one or more joints because it is an unfortunate natural process of aging. The biggest misconception with arthritis, though, is not that we don't have it, but once we have it, we have pain. And I think that's the hardest thing for people to recognize is that just because there's arthritis in an X-ray or on an MRI or the words on the page of their MRI report, that doesn't mean that that arthritis is symptomatic. And it absolutely does not need to hold them back in what they want to do in their life moving forward.
So despite the quote-unquote diagnosis, it's not a death knell.
No, goodness, no.
Right.
Nope. Many people live with arthritis, and there are many people who are doing extraordinary things even with arthritis on paper.
And we don't have to cut that arthritis out of everybody?
No. We can't replace the spine the same way we replace knees and hips, so we just treat the symptoms when it comes to back pain, leg pain, nerve pain, stenosis. Mm-hmm. spinal cord changes, things of that nature. We try to work on treating the symptoms and not the whole picture.
Do you find that patients will find these symptoms or words on a page, say from an MRI report, and just do their own internet search and come in with what they suppose a diagnosis is and maybe be a little bit off mark?
A lot, Scott.
Is that right?
A lot. And part of the problem is that some of those symptoms don't always mean what that diagnosis is. The internet itself can give you a generalized skew of what the symptoms are and how they come together, when in fact, the physicians and the PAs that work with our physicians here at Fox Valley can see you as a patient, listen to your history, do a physical exam, and look through any imaging you have and come up with that diagnosis that works for your symptoms. Because those symptoms can mean lots of different things. People can have numbness in their feet or their hands for a lot of different reasons. It doesn't have to come from a pinched nerve in the spine. And when it comes to pinched nerve pain, people think that those pinched nerves always have to come from the spine, when in fact there are nerve things that can be pinched, like carpal tunnel, where you work a lot, that isn't a spine surgery that fixes that. The other piece of that is when you do an internet search on the words on the page, like an MRI report, if it comes through their portal, for instance, all of those words on the page, for the most part in the spine, mean arthritis in some fashion. I just say that they're big, fancy Latin words for arthritis, because you have arthritis too. And so that's a big thing. We're all going to age. We're all doing it, and there's nothing we can do to stop that. But searching your own symptoms and those words on a page may in fact put you in a completely different direction that sends you in a wrong diagnostic field, when in fact it could be just as simple as having arthritis and ending up in our physical therapist's office to allow your life to move better with better quality.
Yeah, I never have a problem with a patient looking up something online as long as they come and talk to us about it and get the information so that we can put the whole picture together for them.
I like to say that the internet and the radiologists and their reports are really bad art curators. They're really good at describing the small bits and pieces that are going on inside that MRI. But we as the physicians and the providers, we're the gestalt, right? We see the whole Monet for what it is. All the dots and all the lines on the page equate to what your symptoms are telling us and what your physical exam is showing us. Then we use your diagnostic imaging to come up with that plan and confirm what we think and help you move on.
I think that's a great way to put it. Thank you for sharing the information about the frequently asked questions, about going over internet searches. I think that's really important for our patients. And the other important thing for our patients, and what this whole season is about, is innovation. Where are things headed, do you feel like, in spine care?
I love that we're innovating, but I think some of our innovations are coming out of the hospitals and into our surgery centers. And so while we're doing the best we can to come up with new products that help our patients do more with their spines and keep more of their spines, I think some of the innovation that we're doing is actually more minimally invasive work that can be done in an outpatient setting. So with our surgery center here at Fox Valley, we do a lot of spine surgery where the patients get to go home the same day. And I think that the care that they get with our team at a surgery center, where it's our staff and our nurses and all of our providers where we're here working, they're getting better care with, I think, less risk of infection. And in that minimally invasive approach with outpatient surgery, we're doing more for our patients where they're getting back to their life quicker.
What are some of those minimally invasive procedures?
So one of the big things that I do personally is a minimally invasive lumbar fusion, where I go in from the side or in an oblique fashion. Now that is coming into the surgery center world, I hope, in 2026, but I'm currently doing it at the hospitals because of coding. And at this time, those patients are all going home. So I'm able to do a small incision through their side, right above their hip bone, and take out an entire disc or two, fuse up that disc with an implant, and then throw screws in from the back in a percutaneous fashion. So a lumbar fusion can get done in some very small incisions without having to open up their whole back and stripping all of their muscles in an open approach. That way they have less pain, quicker recovery, and they're able to go home the same day. So that lumbar fusion, while it used to be you're staying 2, 3, 4 nights in the hospital, with a lot more back pain gets done in a lot less of an approach.
So less worry about narcotics, less worry about infections. Yeah, that sounds like a great procedure, a great way to move forward. What are some of the other procedures that you've been noticing lately that have been improving patients' lives?
So one of the trendiest ones that I'm going to that I can talk about is cervical disc replacement. Now, I call it trendy only because it's still creating a trend, but it's been with us for about 15 plus years. And so disc replacement in the neck or the cervical spine has taken a lot of traction, and the long-term studies show that it's more beneficial for patients that are younger and older in the long term, meaning there's less adjacent segment degeneration or less risk of needing more surgery at other discs around it because we're creating another mobile segment. Meaning, if they have a herniation with arm pain, instead of taking that disc out to lessen the arm pain and replace it with a shim that fuses them, we can give them a new implant, just like a knee or a hip, that replaces the disc joint and allows the joints to continue to move. And for me, the disc replacements become a nearly 100%. Now, there are certainly contraindications to doing that, but anyone who I think could be a candidate for disc replacement is going to get one.
What are some of the contraindications, would you say, to that disc replacement?
So the biggest contraindication that we see is a fancy Latin word called spondylolisthesis.
That's a great word. I love that one.
It is, but it also means arthritis. And so what that arthritis does is it shifts the bones forward and backwards. And so if the bones are abnormally shifting through the degenerative disc, then putting a mobile disc back in to continue to abnormally shift would be that contraindication. So those patients who have that word on their MRI report or something we see in their x-ray would be a contraindication to a mobile disc and would have to have a fusion surgery.
And do you find that doing a disc replacement for patients with neck pain is the way to go, or are there other symptoms we're looking for when we're doing those disc replacements?
So disc replacements are done for neck pain, and they're done for pinched nerve pain. So radiculopathy is the fancy Latin word for that. And I'm also doing it for symptoms of myelopathy. So myelopathy is when the spinal cord is being compressed by the arthritis or disc herniation. And we take out the arthritis by removing that disc and continuing to allow that disc to have motion by giving a disc replacement. So anyone in the neck without the slipped bones or the spondylolisthesis can have a disc replacement for the most part. And that's whether it's axial neck pain or neck pain, pinched nerve pain down the arm, or spinal cord compression that gives them a word called myelopathy.
And that's the weakness in the arm and the pain shooting down the arm.
Pain shooting down the arm is radiculopathy, but the spinal cord itself doesn't hurt. So that's a big funny thing that people have a misconception about, is that why would I need spine surgery in the neck if there's no pain? The spinal cord doesn't hurt. It creates other symptoms like numbness in the hands, weakness in the hands, or balance problems.
And that's when I'm referring some patients to you who think they have carpal tunnel, and they come in and they say, oh, I don't think this is carpal tunnel. This might be, but I have no neck pain. Like, yeah, I understand, but. So.
It's a tough conversation to have with patients because they think that surgery is done for pain and pain alone, when in fact, myelopathy surgery or spinal cord surgery can, in a lot of fashion, be preventative care to prevent that symptom from getting worse or to prevent them from having problems down the road.
And then they may end up with permanent weakness, which we certainly don't want, and not just in the arm, but even in the legs, like you had mentioned, their altered gait.
Yes.
Have you noticed any changes in the cervical discs over time?
The actual implants themselves?
Exactly.
So the disc replacement that I use has been on the market for about 15 years and one of the original ones. But there's definitely a lot of companies who are trying to innovate to make them a little bit more squishy, like the actual disc. And so there are a lot of companies who are trying to find ways to mimic the disc itself. Certainly all of the implants that are out there mimic all of the planes of the neck. So there are 6 planes, the up plane, down plane, rotating from side to side, and the tilt. And so all of them allow for 6 planes of movement. But the innovation has come in trying to create an implant that's a little bit squishier, like the actual disc itself. I don't think that matters as much, as we've had a good track record with a lot of the ones that are out there.
Yeah, and it's important to innovate, but make sure we're doing right by our patients at the same time.
Absolutely.
These innovations are fascinating to me. To know that you can do some of these big procedures that used to be 4 to 5 days in the hospital, now just in an outpatient center in the ASC, To have a neck that can move rather than be stuck in place and help prevent problems up and down the spine is just amazing. Is there anything our patients can do to help improve those outcomes even further?
Sure thing. So in my office with my team, I always make my patients part of my team. And so I find that when the patients buy into what you're going to do to help them, then they're going to be able to help themselves even more. Some of the most challenging modifiable factors that we have are two really bad habits. Number one is smoking cigarettes. And that, as an addictive quality for some patients, is an extremely bad habit that does a lot of bad things to our body. And I know all of our patients' doctors tell them all to quit smoking. When it comes to orthopedics and the spine in particular, the nicotine in our cigarettes makes our degeneration actually happen faster. So it can make us age faster on the inside and make our discs degenerate even faster. But in some of those patients who need lumbar fusions or even cervical fusions, or fusion in general, the cigarette smoking and the nicotine in that will make that fusion not happen as quickly or maybe not at all. And so quitting smoking ahead of surgery and not having the nicotine in your system is almost now imperative for you to have a fusion surgery, unless there is an emergency, obviously. But in an elective surgery, we want you to be smoke-free so that we can get you the best outcome so that we don't have to do a surgery a second time. The second piece of the smoking is that with anesthesia, and we're still using general anesthesia for a lot of spine cases, that can have a negative impact on your lungs, obviously, and having that breathing tube down. It can make it so that you are more prone to having some medical complications. So as part of that team approach, we ask you very nicely to quit smoking. So the second one is trying to make yourself as best a physical human as possible. So in cases where we're doing multiple lumbar fusions or even one lumbar fusion, back to where we were talking about physical therapy, having the best physical shape that we can be in will help us minimize some of those risks associated with surgery, but also improve our motivation and our physical outcomes. So when we look at some of our patients, we may say that we're doing really well, but some of us have a little bit of weight to lose. And so we talk about our patients about healthier lifestyles, sometimes nutrition changes, and sometimes some healthy activity modifications. Using our physical therapist to find a good exercise program that won't induce so much pain and allow them to get physically fit ahead of time will again help with those physical outcomes. We have a program called Prescribed Fit at Fox Valley, which is kind of co-chaired by the doctors, where we're using our friends at Prescribed Fit to help our patients with that lifestyle change. It is a virtual, although personal, tool that we have where the individual patients will get coaching on some nutritional changes, some lifestyle changes, in the hopes of bringing their weight down to a healthier balance so that they don't have as many complications or risks associated with surgery.
So just by using Prescribed Fit, they can reduce the risk of the fusion not holding or infections or improve their postoperative pain probably.
That would be nice.
It's so incredible to hear about the evolution of spine surgery driven by these technological advances, but not only the technological advances, but how we view our patients and how we, like you mentioned, make them part of the team. It is really incredible and certainly encouraging for me to hear that. If you don't mind, I'd like to circle back to a little bit about what we mentioned in the beginning of spine care, traditionally being a male-oriented specialty. I'd like to just brush on the importance of women in this specialty and improving the diversity there. How do you feel female spine surgeons can bring diverse perspectives to impact patient care?
We need more of us, that's for sure.
That'd be a good way to start, right?
Continue to bring those perspectives out into the open. There are few of us, but I think that our voices are louder for patients to hear. I tend to find a little bit more time in my day to sit with them and to educate and to listen. And I think the women's perspective that we are all here trying to make a difference rather than just trying to get through the day, I think that it's that perspective that I have in each individual patient care to try to improve their quality of life, what their goals are, and how to help manage that in a way that suits their needs. I don't think that perspective is shared amongst all of them, and that's not to say that the genders are different in that fashion. But I think that we as women have a tendency to listen just a little bit more and think outside the box a little bit differently when it comes to managing patient care.
Does that having a diverse team inherently foster more innovation, would you say?
Absolutely. I think that there are voices that come from all different spaces, and whether that's a gender differential or an educational differential or even the levels of our team members. Care team coordinator in my office, my nurse in my office, and my physician assistant in my office, we have a great sense of teamwork, and our patients can feel that, knowing that at each level that the patients are being cared for as a whole. But having the diversity amongst the different team members and within the group as far as our company, having men and women in different fields, having men and women in different spaces, and having different perspectives from all across the company can help innovate in how we manage our patients and how we help them achieve their goals.
That is so perfectly said. That's just wonderful. Thank you. And then to achieve those goals and to make certain that you can do all that you possibly can do, how do you advocate for yourself?
I have a voice and I use it. Typically, sometimes it gets me in trouble, but try not to do that as much as I can. I try to ensure that I'm advocating for my patients in the best way that I can. And in advocating for my patients and how they get their care is also a way that I can advocate for myself in the way that I establish that patient care. So having good mentors and having people you can look up to and talk to and brush ideas off of and ask good questions, that's the way that I advocate for how I'm treating my patients and how I'm performing my surgeries and how I'm running my practice.
That was interesting. You mentioned about having good mentors. And where can young people go to find some of these mentors?
My mentor from my residency was someone who was there. And it was an unexpected relationship that he took me under his wing, showed me all of the ropes of spine surgery, and I give him the credit of making me who I am. Now, he's always been part of my guiding light as far as jobs and situations and different surgeries and different perspectives of different things. So he's been my mentor and my friend over the course of my whole career. For the young people, it's finding people who are like you, but also find people who will help you. And so I have no female mentors, and I never did. It doesn't mean that I wasn't going to be a female spine surgeon. It just meant that I needed to look for advocates who are going to help me rather than be like me. And I think it's important for young women to see people like themselves, other women who are spine surgeons, if that's the field they want to go into. Now, for this day and age, many of us are on social media, and so there are a lot of people who can reach out to us even through Instagram and such. But that can be a little challenging when you're flooded with direct messages and such. But the idea is finding people in the field that you want to talk to, that you want to be like, and who will help you achieve those goals.
Do you think those people necessarily have to be in the exact subspecialty, or do you feel you can get some of that mentorship elsewhere?
Initially, you'll have to find people who probably aren't in the subspecialty you want to be in. But also initially, having an idea of that exact subspecialty may change a lot over the course of your education. So finding the voices and different mentors in different spaces and just getting you in the direction of where you're going is always helpful. So whether that's science mentors in high school, different mentors in college, even neighbors and friends and family members who might have resources for you or people that you can speak to. Getting your feet wet and your eyes opened by different stuff is equally as important as finding the right person.
And I think that can make you a very well-rounded person as well. So, you meet these people who are important in your life. They may not even be in the same specialty, but you can learn a lot from them. One thing I'd like to talk a little bit about, if you would, is imposter syndrome. and how we get through that, or how we cure that, or...
I don't know if that's curable. I mean, I think at some point you can move past it, but I felt even imposter syndrome just a few months ago. I was at a conference of all women spine surgeons, and that was a challenge for me to be amongst my peers because I just didn't feel like I was one of them. Exactly. I know. Part of that is because we're all in different practices. And a lot of the women I was hearing speak were women who were in academic situations and learning a lot through research and mentoring in those programs. I'm in private practice, and I think I do a really good job with what I do, but I'm not at the level of some of my other peers who've been a spine surgeon 20 years longer than I have. And so sometimes you just get into a situation where you get a little bit of a girl fan going on and you don't quite feel like you're at the same level. And so imposter syndrome can be very real, even in the setting of all women spine surgeons.
Well, I can say without hesitation that you're one of the finest surgeons I've ever worked with, and that's not just for the podcast, by the way. And I think that this goes back even to the mentorship in somebody who's so well established like you are and so skilled, how you can see these other people and still look up to them almost as a mentor would. Do you feel as if having imposter syndrome may even motivate you to make certain that you do as well as you can for your patients, that you don't slip things up?
I don't think putting that much pressure on yourself is also that helpful.
Well, that's probably true too.
But I think imposter syndrome in my day and age is more in the setting of conferences around orthopedics. So that last example, being in a room full of women, was very rare. And so most of the conferences that I've attended over my years has been in a room full of men. And you absolutely feel like an imposter in those rooms because there are very few of us women. And a lot of the women in those rooms aren't surgeons. There are the doctors, physician assistants who are coming, or nurse practitioners who are coming. And so striving to be the best that I can be has always been a part of me. And that's, I think, every surgeon and every orthopedist out there. But you certainly don't want to put so much pressure on yourself that you feel like you have to be better. Because then the enemy of good is being the best, and then you start to make more mistakes. So I don't strive for perfection in myself. I strive to have the right surgery for the right patient at the right time. And that way we have the perfect combination of things for that person to meet their goals. And my goal is always to make my patient better and not have problems.
Would you be willing to talk a little bit? You were talking about mentors. Would you be willing to talk about Boss Lady Docs?
Boss Lady Docs is a program. I think program's maybe the wrong word, but it's a group. And it's become a program in its own right of all women physicians in this area. So it started in 2020 during our lockdown, essentially. When I joined Fox Valley in September of 2020, I wasn't able to meet anyone in person. And coming into this neighborhood, having no access to other doctors and referral sources and knowing where my patients are coming from, I reached out to everyone I could over text message. And at some point, we decided that we were going to have a little happy hour over Zoom because that's what people were doing those days. And then it developed into in-person happy hours when we were told we were allowed to after vaccinations. And that has grown now from a group of 5 in the original Zoom happy hours to now 240 women physicians in our area.
That's pretty impressive growth.
Thank you. And these women are not surgeons only, and they're not all internal medicine doctors. And they are, but they're all women who practice in the general vicinity of the Fox River Valley. And so it's primary care, family practice, ENT, anesthesia, people who are employed by hospital systems, people who are self-employed. And there are many women physicians now in the group who were practicing and are now in different roles in administration. And so the only requirement to being a part of this is being a lady and being a doctor. And we're all bosses in our own right. So we help each other with patient care. We help each other with anything that we're doing even around our house, trying to figure out our gardeners in the area, landscapers, roofers. Who likes a dry cleaner? Who needs a nanny? And so all of the regular things that we as women do to take care of things around our house and build our home for our families, we're utilizing each other's knowledge and time to make our lives a little bit easier. But in the same setting we're doing that, we're using that just as much, if not more, to help our patients gain access to each other. Right now, access is extremely difficult. And with all the hospital systems going in different directions, it can be really challenging to get a patient who has a need that can be pretty urgent, like a patient in diabetic crisis, to get in with an endocrinologist if they're booked out 3, 4, 5 months. Mm-hmm. And so we're able to come to each other on this chat group and ask to help our patients in need and find out who the right subspecialists are for a certain symptom. Boss Lady Docs as a chat group is also used a lot for patient access. In this day and age, with the healthcare systems being larger and even spread thin, our patients can sometimes find that access to subspecialists can be really far out. So there are certain primary care doctors who manage subspecialty things like diabetes or diabetic crisis and may need the help of an endocrinologist, but they're booked out several months. So with access to 240 doctors in lots of different areas and neighborhoods, we're able to get our patients the access they need, maybe in a lot shorter time period than what their own hospital systems are allowing.
Another way to innovate.
We are truly trying to do that for each other.
Dr. Matteini, thank you for spending some time with us today. This has been very interesting for me, and I hope for our listeners as well. We're going to wrap up the session today with my favorite part, or one of my favorite parts, is the rapid fire questions. So these are just mostly lighthearted questions. Just answer as quickly as you can. But let's start off with, what's your favorite thing to do to completely unwind after a long week?
Puzzles.
Do you like really big jigsaw puzzles?
1,000-piece jigsaw puzzles.
Okay.
It's my Saturday afternoon with a glass of wine.
So fun and so frustrating at the same time.
Create order out of chaos.
That makes a lot of sense. Is there a movie you can quote from start to finish?
Start to finish? No, but I can probably run you through most of Old School.
That's a good one. Is that your favorite movie, or would you say you have a different favorite?
I don't know if it's my favorite, but anything with Will Ferrell really gets me chuckling.
There you go. Are you a Harry Potter fan?
Yes.
Which Hogwarts house do you think you would be sorted into?
Ravenclaw.
That was like a very quick answer.
Mm-hmm.
What is the most used emoji on your phone right now?
Probably the heart hands.
Coffee or tea?
Coffee.
Why?
Always.
Just always?
I mean, coffee every morning and tea most nights, but tea is a newer thing for me.
So you're still exploring that part of it?
It just becomes a nighttime, end of the evening, before bed thing. But coffee is an absolute everyday. I can survive without tea. I cannot survive without coffee.
Gets you moving. If you had a theme song, what would it be? Yeah, our director came up with some really good questions this time.
Oh, man, a theme song. Oh, pass. Let's come back to that.
Okay, we can come back to it. Are you a morning bird or a night owl?
Oh, neither.
You're like the middle of the day.
Like literally, I hate getting up in the morning and I hate staying up late. But yet somehow I picked a morning, job.
Yeah.
And I end up staying up too late anyway. But I like sleep. It works out.
What's a minor thing that instantly makes you happy?
My dog.
Like when they greet you right at the...
She puts a towel in her mouth when she comes up from downstairs, and she has this big gaping smile on her face and pulls her ears back and wags her tail, and she's just so happy to see me. So,
do you have any secret skills?
I can wiggle my ears.
Can I see that, please? Oh, yeah. My grandfather used to wiggle his ears. That's a huge favorite of mine. Any last words to leave our audience with today?
Nope. Other than, be the boss that you are as any lady who wants to go into medicine. And, don't be afraid of your own arthritis. It's like being afraid of your shadow. You can't hide from it. It's going to be there any day.
Did you want to answer that question about
the theme song? No, I don't know. Trying to think of a good one on the spot.
Great questions, like I said, from
right.
our director, Hope.
Nope. can't come up with one right now.
Well, this really was a great way to start out season 2. I really appreciate you being here today, and there'll be more to come for our Ortho Out Louders in the coming weeks. Thank you very much.
Thank you for having me.